Hello, everyone. My name is Suraksha. I'm a health correspondent with Deccan Herald. This is our fifth edition of DH Sparks, our webinar series. Today, we will be focusing on when and how the COVID-19 pandemic will end. In our previous editions, we have focused on the effect of the pandemic on various sectors like cinema, sports, finance. We've also looked at parenting during the pandemic. India has reported more than 20 lakh coronavirus cases, and it has seen more than 40,000 deaths. Karnataka accounts for 1.5 lakh of these cases and close to 3,000 deaths. The government's strategy for this to deal with the pandemic was to impose successive lockdowns. And as restrictions started lifting and the government of India has tested more than 2 crore coronavirus samples, now we are seeing an exponential surge in COVID-19 cases. We are joined by a panel of experts to tell us what our best response can be with the pandemic, and the most important reading question on everybody's minds: when and how this pandemic will end. We are joined here today by 4 eminent panelists. First, Dr. C.N. Manjunath. He's the director of Giridhar Institute of Cardiovascular Sciences. He's also the state nodal officer for COVID-19 testing. We also have Dr. Giridhar Babu. He is a head of life course epidemiology at Public Health Foundation of India. He's also the member of ICMR's Epidemiology and Surveillance Research Group. We have with us Dr. Vishal Rao, who heads the state plasma bank, and he's a head and neck cancer surgeon. He is also the associate dean of HCG's academic center for research. We also have Dr. Shashikumar Ganeshan, a mathematician from Indian Institute of Science. He chairs the Department of Computational and Data Sciences at the Institute. Many thanks for joining us, gentlemen. Thank you for joining Deccan Herald in this webinar series. Dr. Babu, if I could start with you first. India, for a couple of days, reported more number of infections and deaths than Brazil and the United States, which are the most affected nations by the pandemic. So where do you see the pandemic going from here? How do you see it panning out from here?
I think after the initial surge in cases in Mumbai and Delhi, now most of the other cities which are densely populated, the suburbs and the large clusters of villages where the population density is higher, that's where we'll see the surge in cases. However, just the rise in cases should not be of a matter of concern, because absolute numbers do not actually mean anything in a vast country with a vast population such as India. If you look at the death, instead of case fatality rate, it is better to look at death per million. India's death per million is around 27 deaths per million population. If we look at all the countries which have more than 100,000 cases, their death per million is 157, which 27 to 157 comparison, definitely we are having much lower mortality compared to the other nations. Not just India, the other South Asian nations also have similar death pattern. So this we need to sustain in terms of reduced mortality rates. And in order to do that, clinical management is the most important thing, by identifying those who require oxygen, and because that's the only thing which is saving lives. And how do we detect such people who require, especially those with comorbidities? If you just look at Karnataka's data, 90% of them have some or the other comorbidities, which means that those who are elderly, those who have other comorbidities, if you can identify them early enough, and then if you are expanding the testing, that's the only way we'll be able to save many lives. And that should be the goal as we move forward in managing this pandemic throughout this country. Again, not to worry, the numbers will be there, the surge in cases will be there. No country in this world has been able to contain without having surge in cases. The honorable exception is New Zealand, but surge in cases should not result in panic. The goal should still remain reduced mortality.
So you make an excellent point about increased testing. If I could get Dr. Manjunath, the state nodal officer in Karnataka for COVID-19 testing. Dr. Manjunath, Soumya Swaminathan of the World Health Organization has said that India is not testing enough. So here in Karnataka itself, what are the challenges in ramping up testing? Why aren't we testing enough?
Yeah, if you look at the testing, actually, in April, Karnataka had only about 7-8 COVID-19 labs. So today we are close to having 100 labs actually spread across state. And in Bengaluru itself, there are about 32 COVID-19 testing labs are there. So maybe till May, we are testing about 5,000 tests per day. So in the last 10 days, we are reaching close to 40 to 45,000 tests are being done daily. So really, we have scaled up testing. And with the addition of rapid antigen, so we have really ramped up the testing. So as we test more and more, naturally, linearly, we are going to get more and more number of cases. So that is one thing. And so randomly also we are testing, particularly those high-risk population are those like healthcare workers, frontline workers, police, marketplaces, or earlier containment zones, Paura Karmikas, or even the sales boys and the railway station staff, KSRTC, BMTC staff. So clusters, see what we are seeing here, the more cases are coming from clustered houses where there is virtually no distance between the houses, and those have become real clusters of spread. So we have three types of testing today. One is RT-PCR, which is the gold standard. The second one, we have this CONAT or CBNAT, and third one is rapid antigen test. So all put together, we are ramping up nearly 40 to 45,000 per day. Goal is to have 50,000 per day. In Bangalore itself, yesterday and day before, we have tested close to 18,000 in Bangalore itself. So as far as testing, there is a significant improvement. And most importantly is people with symptoms should come forward. People with primary contact should come forward for testing, because there is fear. If they get tested, oh, they have to get isolated, they have to get quarantined. That fear should go. And obviously, even fear syndrome is also getting into fatigue syndrome. So slowly fear is coming down as more and more of our neighbors are getting infected and being recovering, and they are cheerful. They also, the stigmatization will slowly disappear.
Right. So before I go on to our other two panelists, I request our viewers to send in their questions as soon as they can. Let's have our first poll question too. So for the benefit of our YouTube and Facebook viewers, this is our first poll question. How do you think the pandemic will pan out? And the options are, it will peak in October, see a downward spiral in March 2021, continue beyond March 2021, never end. So I request our viewers to answer this question, and we will see what the results are in a few minutes. Dr. Ganeshan, if I could get you, yeah, are you with us, sir? Sir, you have worked on a mathematical model where you have played out 5 different scenarios on how the pandemic will progress. Can you tell us how you see the pandemic panning out from here on?
Thank you for hosting. Thank you for your kind introduction. I'm really honored to be part of this panel. Coming to this mathematical model, right? So what we're trying to do in the mathematical modeling is we're trying to describe the dynamics in terms of the mathematical equations and close these equations with the right parameters and then we solve this equation trying to estimate or trying to do the scenario analysis. When it's a scenario analysis, we fit most of the parameters and then vary one or two parameters and trying to see what would happen if this happens or if this had happened. Right? This is typically the mathematical modeling and so on. So coming back to the very particular pandemic or even any infectious disease spread. So what we feel is there are 3 or 4 key parameters. So the first parameter is when you do this computations or any mathematical model, the initial condition is very important. On the day of 0 of simulation, how many cases that you're going to consider positive cases. We will take even the specific example, COVID. So on the day of 0, that how many infection cases are you starting? That's the very key. If you change if you start with the different numbers, you end up with the different numbers. That's the typical mathematical way. And then the next very important factor is the R0. People talk about in epidemiology, right? So it's nothing but how you are getting infected, right? So, and then the next parameter is the infectious death and also the recovery rates. So all these 3 parameters are very key, and if you're able to fit these parameters correctly, then our estimates will also be perfect, close to perfect. So if you look at these existing models, using all these parameters by solving these equations, the models predict mainly how many infected cases will be for the next 30 days, will be there for 1 year and so on. That's like number of infected cases. And then how many deaths and probably how many are recovering and how many are going to be the susceptible population. All these parameters or numbers will be calculated. So if you look at our model, what our model provides in addition to these numbers are the distribution of these numbers across the age of the population and across the infection level and across the age of the disease. So these insights are key, are very, as Dr. Giridhar mentioned, right? So it's not only about identifying the number of cases and also identifying needy people to get treated. So that's most important. That's the insight that our model is going to bring. So in our model, in addition to these parameters, what are the other parameters are importantly considered are the social distancing is the one parameter which is included in the model. And the interactivity index is also included in our model. Hygienic index is included in our model. And another most key parameter is the quarantine rate. So are we capable of, if we have like, if you're identifying tests comes to like 1 lakh, but are we able to quarantine all 1 lakh people? If you're able to completely quarantine the entire infected population, then definitely there will be no spread, but that's not going to happen. Practically, that's impossible. So the quarantine rate parameter is also one of the key parameters. So we fit all these parameters based on the data from March 23rd to June 6th. And then what we have done is we vary the social distancing parameter from 0.75 to 0.81, and we do perform the different scenarios, and then we perform the scenario analysis. So based on that, what we have seen is from the March towards end, and even we can see clearly from the May, what we can see is that the recovery rate is getting better and better. There are several reasons. One could be we are probably because the test has also been increased. When we increase the test, obviously we will be identifying more asymptomatic patients. The asymptomatic patients will recover definitely, and also we are able to capture more and more test cases. Even the patients with the less infection will also get identified positive, tested positive, but recover. There are several reasons why the recovery rate is getting better. But as Giridhar mentioned, so another important key factor is the fatality. So that rate is also, it's not a panic, still under very much control, especially in the South Asian countries. That's also another key good terms, what we are seeing from the data for the last 2 months. So these parameters, especially the recovery rate is getting better and better. So because of which what we are seeing is, if you follow the current trend, if the curve follows the current trend, probably we are expecting the peak somewhere at the end of October. So when I say it's a peak, active cases. Obviously, when the active cases start to decrease, then the new infections will also start to decrease. Obviously, then the curve becomes flat and so on. So it's a good sign. And also we have done another 4 scenario analysis, and one is like a better scenario analysis. It looks like it's very difficult to follow the better scenario analysis in the country like India. It's not only the population and the behavior and given the big, very big population and so on. And we have done this worst case scenario. Even the worst case scenario in the July model, what we have seen is we did not see any peak. But in the August model, what we are seeing is, even in the worst case scenario, we are seeing the peak somewhere in the end of December. So this is because of mainly the social distancing. Of course, we are keeping the same, but this mainly reducing, or we are seeing the peak mainly because of we are getting the better recovery rate. So if you follow the different scenarios, yes, we are going to see probably the October is the peak, and in the worst case scenario, we are expecting somewhere in the December. But having said that, all these projections, again, right, these are only the mathematical projections, and the problem is very, very complex and very non-linear. If you change the parameters a little bit here and there, then obviously the results will be completely changing. And then these parameters highly depend on how people are going to follow the social distancing, face masking, hygiene levels. And in addition to that, all our parameters are fitted based on the data. And the data comes from the testing. And if the testings are really good number of testings are performed, and the data which you are getting from the testings are good, then whatever the parameter which you have fitted will also be good, and obviously the mathematical model will also give the right projection. Right. So overall, it's highly dependent on a lot of things, not only about the people behavior, it also depends on the testings as well.
Yeah. Dr. Vishal Rao, if I could ask you to step in at this point, Dr. Ganeshan says that in October, the cases are likely to rise and peak, and in December, maybe there will be a downward spiral. So you have been involved in a lot of COVID research, 3 clinical trials, I'm told, one on convalescent plasma, one on repurposed herbal drugs, and the other on cytokine therapy. So where are we on the vaccine front? India has 3 vaccine candidates. World over, there are about more than 200 vaccine candidates registered, and 6 of them are in the final clinical trial stage. So where are we on the vaccine front?
Sure. Thank you, Suraksha. First of all, just to give you a brief background, March 13th, we were supposed to be in London. Dr. Tedros, the Director General of WHO, along with Mr. Michael Bloomberg, who is the UN ambassador, and Sadiq Khan were hosting a WHO United Nations meeting. I was one of the speakers. We were all going for non-communicable diseases. About a week back, they sent us an email saying that the meeting is confirmed. We are all going ahead with the meeting, so please do not cancel your tickets. And about just 3 to 5 days before, the meetings get postponed because the health minister get affected. So that's when we actually started talking on communicable diseases in the non-communicable diseases forum. And I think Manjunath sir here would agree that a lot of hit has happened specifically for non-communicable diseases. Somewhere today, non-communicable diseases, which we think are actually protected, are actually the most vulnerable. They've all been exposed badly. So that's when the first discussion began, and I'm still in touch with all the groups whom we were all supposed to meet from more than 50 countries there, where we've been discussing on regular reports on vaccine. Now, there are some couple of interesting things that we found. Among, I think, about 177 efforts are being done in vaccines as of now. Just before we started, Manjunath sir said even vaccine is becoming a pandemic now, which is true. Now, if you see this, the 177 people who are going into trials, about 20 odd of them are going into phase 3 trials. What is important to understand here is that all of them, and I'm in touch with at least 4 or 5 of such groups, they are all pretty much amazed and confused. Now, the reason for this, I'm telling way back in 1938, Winston Churchill said something very beautiful about Russia for the World War. He said it's a riddle wrapped in a mystery within an enigma. And the same is true for this virus. We are today, all experts put together, not able to decode the virus, whether it's a viral. In my core team, I have the Elsevier's Lancet Resource Center partnering with HCG as an academic and research partner. We have virologists, immunologists, we have our clinical team of pulmonologists put together. We keep discussing almost every second day, and we have not been able to decode. The answer is, recently what we found is among the people, for example, patients who have come forward as donors. Now, some of them who are asymptomatic, okay, we found good amount of immunoglobulins, which are the IgG antibodies. Whereas people who were in the ICU, breathless, who have come out of it now, when we test their antibodies, there is no antibodies at all. So there is a very paradoxical trend that we are actually observing. And the same is being experienced by vaccine experts. So which means if you give a vaccine, you are supposed to ensure that there is going to be a good amount of immunity built up so that you don't get the infection. Now, how do you prove it? By proving that there is already immunity and antibodies developed for it. The question is, how long will it be developed for? Will it last for a few days? Will it just go off in a few months? Or will it last for a year? Now, earlier experiences with SARS and other viruses have told that it can last for 1 year up to. But that is not true with the COVID-19 today. So the questions that baffle us today are, even if you have a vaccine, how long will this immunity last? And how do you prove this, that this is immune against the virus? The person who gets the vaccine has to go front of the virus and bow down. It's a difficult task. It's not going to be easy. So all clinical trials that are being attempted today are going to have some significant hurdles, which is where we are estimating that by March, I'm looking at March, being optimistic that each of these hurdles that we're going to start. Now, in this, one important point again to consider is, whenever we do a clinical trial, you have several phases. That is, you have a preclinical phase, which is animal studies. Then you have phase 1, which looks at safety. Phase 2, which looks at efficacy. Then after that, phase 3, which looks at comparative studies. Then phase 4, post-surveillance. It's not going to be an easy task. And a lot of them will fizzle out at that. But yet, the only answer is to make an attempt, to make a sincere attempt. Because I understand it's very easy for us to criticize and say, oh no, that may not work. But the point is, somebody will have to do this effort. And that Herculean task is being conducted today across the world by 177 groups. And I think they should be applauded for the attempt they are making. More than 80% of them or 90% are going to fail. And the attempt is going to be, what can we do? The other point I want to mention, what Shashi said, Dr. Shashi Kumar said, see, very interestingly, the R0 is what we are all talking about. I was talking to the Elsevier's team, and they were giving me a very interesting perspective about some of the recent published work, that R0 is a very difficult indicator today. Because, for example, R0 says that the R0 of the virus is about 2.5, which means one person can infect up to 2.5 people. But this also has a temporal trend, which means the first techie who came in and got infected met with 2,000 people before he actually got himself tested. So this is going to be a very dynamic one. And today we don't know the true number. In India, the biggest point is we are not going to be like the West. We are going to be having PCR everywhere. Manjunath sir has been laying down a Herculean task of arranging machines, looking at setting up labs. It's a Herculean task. So we don't know the true number. So on a comfortable estimate, you just multiply it by 3. That would be the true number on a comfortable estimate. And that is what we will need to be prepared for. And rightly, like Giridhar pointed out, the numbers of mortality are very less. And I have 2 theories for it, which I published. One of them, which is under review, one which has been published. One, which is that we found that among the people, when we were discussing it with the veterinary team, I was discussing it with the Cessna group and others, the coronavirus has been present. The coronavirus has been present for the last decade among animals, especially among stray dogs and among cattle. Now, India is a home for 3.5 crore stray dogs and 15 crore cattle, both of which have been harboring this virus. And both of these, especially the canine coronavirus, has been having some spike proteins, which are very similar to the human coronavirus, 7 strains of it. And the ACE receptors of dogs are very similar to human. So what we believe is, much before the coronavirus came into India, the Jan-Feb phase, we've already got some cross immunity through interspecies transmission, which is possibly explaining scientifically the reason why we are immune against certain mortality. One possibility. I'm just putting this as a hypothesis. The second, what I have put up in our paper, is one of the key things that our immunology lab found as an important thing, and I want to give due credit to Dr. Gururaj and Dr. Jyotsna. Now, Dr. Jyotsna was one of the researchers who was working with Ralph Steinman, the Nobel laureate who actually discovered the immune system. So when we were putting our things together, we found that the key important aspect here was that the thymus gland, which actually recognizes the antigens. Today, all the discussions around the immune system are happening around the T cell. Now, our lab here actually works on the T cells, looking at activating them, looking at studying them. And we've been working on this quite a long time because we've been working on cancer. Now, the funny combination here was virology and oncology are close friends because viruses cause cancer. So while this pandemic evolved, our immunology lab took up the virology aspect of it and we started building upon it. And what we found was this thymus gland is a key role that is playing. And if you see, like what Giri said, that the mortality is higher in the 65 plus age group. This is the classic age group wherein, because of comorbidities like 65 plus, the thymus glands gets degenerated. And that's why they are also more prone for the viral attacks because of the immunological hit that they've already taken because of the degeneration of the thymus. Now, the thymus is a gland below the thyroid gland which actually recognizes new antigens. It recognizes new viruses and then builds the body's immune system. So I can share the links to the detailed paper we've written on this. That's for interested readers if they want to actually, this is another hypothesis.
Right. Thank you so much, sir. That was a great summary of what's happening on the vaccine front. Can we have the poll results now, please? So this is our 45% of our respondents say that the pandemic will peak in October. That's about 31 people who've responded. 29%, that's about 20 people, say that it will there'll be a downward spiral in March 2021. 19%, that is 13 people, say that it will continue beyond March 2021, and 5 people say it will never end. So I think Dr. Ganeshan can weigh in on what our viewers think of the pandemic.
Yeah, so but okay, if you look at the poll results, right? So people are probably following the whatever the current trend, right? So the current trend shows if we continue, probably we will be having the peak in the October, as earlier mentioned, right? The biggest problem in all mathematical models is how to fit the parameters perfect, right, or close to the perfect. Especially the R0, right? The reproduction rate. It's a very, very difficult to fit, and it varies from, forget about the countries to country, even state to state. For example, if you look at the Maharashtra, they have tested somewhere around 30 lakh cases and 25 lakh tests, and then tested positives or positive tests are somewhere around 20,000 or so. So 20%. So whereas in Tamil Nadu, it's the other way around, probably the 10% positive test cases. So it's very hard even within a country. So it's very hard to fit the parameters. Are we going to, the peak might be in October, but if you look at the poll, yes, even beyond March also there will be a case. Until otherwise, if you're having a vaccine or treatments, then definitely we're going to have we have to learn live with it. So no option. So definitely we will be having the pandemic or at least the COVID cases beyond March. But the peak will be somewhere end of October if we follow the current trend. This is what we are expecting.
Right. Dr. Babu, if I may ask you, in epidemiological circles, are there any contrarian views to what mathematicians predict? Is there any contrarian view from an epidemiological point of view? If you could tell us.
Oh, we are friends with Dr. Ganeshan and all the mathematicians. There is a lot of confusion between who is epidemiologist, who is mathematician, who is what. The pandemic has ensured that people are giving predictions almost on daily basis. But I agree with Dr. Ganeshan's predictions. They are more robust estimates. There are several models done by Gautam Menon and group, and also we published a paper on compartmental models. So everyone is trying to give the best guesstimate based on some certain conditions. But I agree with the other panelists, esteemed panelists, that R0 is probably overemphasized. But what we are ignoring is something called dispersion index. Nearly 80% of the cases are a result of 20% of the people in clusters, especially the symptomatic people in the clusters. And it's no longer a situation where only individual transmission is most important. It is the group behavior which is important. So I can prove Dr. Ganeshan wrong that at the end of October, we'll have a surge in cases just by lifting all the norms today. You ask people to do whatever they want today, we'll have the surge in cases next week or maybe 14 days from now. So it is the behavior of the people which will change when the surge in cases is going to be. And based on what we know so far is that even people with mild symptoms, even those who are having asymptomatic, will have some long-term morbidity. So in order to change that, the only way, even now, is to prevent the spread of infection and make sure that everybody wears masks, not as chin guard, but really for the purpose that is meant to be. And also be responsible in not resulting in any crowds, and in close contact setting, be careful. So if you are following this, probably the number of cases will be lower, mortality will be lower. So it's in our hands. So it's not just the government which has to do its own responsibility. This is the time to ask, what is that I am doing for myself, for my family, and for my society? So there has to be shared responsibility. That's when we will contain the adversities of this pandemic.
Right. So we are getting a lot of questions from our viewers on Zoom, YouTube, and Facebook. So I think we should start taking them. Dr. Nagendra Prasad on Zoom asks us, after the test, it is taking 2 to 5 days to get the report of RT-PCR tests. Why is that? Dr. Manjunath, if you could answer.
Yeah, see, that was the scenario maybe a couple of weeks back, but now actually they are giving the result pretty faster. And particularly if it is done with a TrueNat system, the result is given within the 2 to 3 hours. Of course, if it is done with rapid antigen, it is just given within 30 minutes or 45 minutes. And sometimes what was happening, the samples were being shifted from one place to another place. Suppose say Gulbarga, Yadgir, or Raichur, or maybe Koppal and all. Sometimes they were all being pushed on to Bangalore. There was a lot of overload on the Bangalore centers, Bangalore lab centers. So there was a delay in transport, so also in reporting. So today, even those centers, even in North Karnataka, every district today has got a COVID-19 lab. So as a result, the waiting time to get a report is becoming shorter and shorter. But I agree, there may be some couple of instances where, and another thing is people who are giving for testing are also giving wrong addresses and wrong telephone numbers for the fear that some people, I mean, will catch them for isolation. So that is also another issue that should not be done. In fact, as more and more number of people get infected, definitely everybody will get a courage. See, the fear factor which was there in March, April, now it is not there, particularly in August. So I think that will also boost the morale of people who are having symptoms or who are primary contacts or high risk contacts. They should come forward for testing. And another important thing is going beyond the testing. I wanted to emphasize there was a study from German study that was released. 70% of COVID patients will have heart involvement. So that is not correct actually. It is only a microscopic evidence. That was an MRI evidence showing that 70% of patients with COVID-19 will have an heart involvement, because none of them had a severe heart involvement on echo. So echocardiography done in all these patients was normal. So I want to emphasize again, the significant heart involvement in COVID-19 patient is less than 5%. So it could be in form of, it can affect the heart directly, cause what we call it as viral myocarditis, or it can also cause clotting, because this COVID-19 is a highly thrombogenic or a clot-prone disease. It can form clots inside the lung arteries, causing pulmonary embolism. Rarely, it can also form clots inside the arteries in the heart, resulting in heart attack, or in the brain arteries, causing stroke. So definitely, coming back to that question, that the response time and and sometimes there can be a problem in ICMR portal to enter this data. So because now nearly 5 lakh tests are done daily in India, as a result, ICMR portal is getting down. So these are some of the reasons, but definitely the more number of labs, the result will be faster.
Thank you, sir. So there is Kabir, a concerned parent, asking, is it safe to send children up to 7th standard to school when it is opened, maybe by end of September? If yes, what are precautions to be taken by the students and schools to have a safe environment? Dr. Rao, if you could come in.
Again, like I told earlier, you know, when we were discussing this, we had earlier met with Dr. Suresh Kumar, and I think Giri was a part of one of those discussions when when Mr. Suresh Kumar, our education minister, was in the quandary of whether to conduct the exams or not. And some of the things, I think Dr. Giri's team, Sudhakar sir, and everybody gave a very detailed report about the public health impact, and he can add to it. I'll give you a little bit of a biological basis. What we have presented in our paper is that children in the intrauterine life itself start to develop the thymus gland. So in the mother's womb itself, the thymus gland starts to develop and within a month is fully active, which means children, if you see the way the mortality pattern is, why is this particular virus latching on to people who are elderly, who have a mature immune system and not having any impact on children who don't have a mature immune system? The reason we have given also is the thymus, because the thymus is fully evolved in children immediately at birth and at 65 years starts to involute and degenerate. So the children's capacity to pick up new antigens, to pick up viruses is very good. So they are able to quickly mount an immune response and kill the virus and eliminate it within a span of 2 weeks, whereas elderly are not. Having said that, you will have children with comorbidities, you will have to take care. And like what Giri said earlier, social distancing, masks, these are going to be the new norms for the new age of education. And that is something that we will need to keep in mind, that when we open school, if you see the guidelines that the CDC has laid down and which Trump has very nicely ignored, has been putting some very stringent guidelines on maintaining discipline for schools, and it's not going to be easy. So I think this is one place where we've learned that any measures that you're going to take to prevent this are going to be at the cost of economy. So I've been on a lighter note saying there has been no right decision. There has been two wrong decisions. Either you sacrifice health or you sacrifice the economy. And there is never going to be a perfect right decision. But even here in schools, if you see world over, they're facing that if you follow the stringent CDC norms, the cost you will have to put in place is going to be so high that you'll have to hike the fees 3 times its current cost. So there are going to be implications to all of this. So finally, the answer, I don't know. The answer is that political decisions have to be based on scientific advices. What Ganeshan said, we need to live with this virus. So there has to be a balance in which we have to open up and with a cautious way.
Right. Kabir, I hope that answers your question. Can we have the second poll question, please? For the benefit of our YouTube and Facebook readers, I will read this out. With all restrictions being lifted, what is the public's responsibility in a post-pandemic world? And your options are resume life with restrictions, resume life as and when required. Third is resume life as if everything's back to normal. We'll have the results for that in a few minutes. So if we could continue taking questions from our audience. There's Vasant asking our panelist, there were models saying that there would be 1 lakh cases in Bangalore alone before 15th August. But why hasn't the government prepared enough in terms of testing, contact tracing, building up manpower in frontline workers? Why has there been no quick policies to hire youth on a temporary basis in health supporting staff, paramedics, nurses, separate group for contact tracing in the police department, etc.? Many things can be done to fight this pandemic effectively, but instead the government is not giving minimal salaries to ASHA workers and police personnel properly. Is there a lack in giving reliable information to policymakers on what exactly is happening? I mean, the question is open to any of our panelists who would like to take this.
Can I take a dive on this first? And I think we can have Manjunath sir give the final verdict on this.
Sure.
Yeah, but Suraksha, I want to just maintain one thing, and this is something I've been continuously talking about, saying that as a simple example, today if I'm attacked and if I know karate, I can definitely defend myself. Now, if I do not know karate, I cannot be watching the YouTube video and then defending myself and telling the opponent, please wait for 2 minutes. So we are not geared up for epidemics. We are not geared up for epidemics. So we have to have like a military operation of a natural disaster management drill, which health systems have never been geared up for. So let's face the facts. Let's not be diplomatic about it. We've not been able to face the facts. Now, suddenly in a week's notice, this virus has come before us, or a month's notice. Our preparedness has been poor. And this is one of the biggest learning lessons for us today, that our preparation for the future has to be investing in health. Our preparation for the future has to be investing in healthcare training. And this is going to be very, very crucial. This is the biggest lesson we have learned today, that more than anything, I think if you see the machinery, whether it's the political system, the bureaucratic system, have put their best foot forward. And yet it has not been easy to put policies overnight in place, which they've been trying to do. So I think the key lesson that I want to tell is, I think key aspect is training. The key aspect is preparedness. There are countries that have emergency ministers today for emergency pandemics. I mean, that's the kind of policy we'll need to put forward in Karnataka and in every state where we have a public health policy which is robust. I think that's what I wanted to make. Thank you.
Actually, it's biological war. So now what's happening? See, nature is always ahead of any technology, and nature is always ahead of man. Actually, so no country can get prepared abruptly. Even you look at United States, which has one of the best medical infrastructure, and when the cases are surging, they are also not able to. In fact, in United States, or even in, for that matter, Great Britain, see, they are telling, even if you are tested positive, and if you are having mild symptoms, they are telling, don't come to the hospital. At least here, what was happening initially, those asymptomatic were also coming to the hospital. As a result, symptomatic people were not getting beds. Now, government has come out with policy, and those non-vulnerable groups, and also those who are mildly symptomatic or asymptomatic, now they have allowed home isolation. Those who can able to take care of them at home. It's this one. Coming to the contact tracing somewhere in the middle, it was lost. For the last 1 week, again, it has picked up in Bengaluru, because contact tracing, and people also should be honest enough. Preaching and practice should be same. Fortunately, in this country, there is a lot of gap between preaching and practicing, and 10, 15, at least 10 to 11% who have given swabs for testing have given a wrong address. They've also given a wrong telephone number, and instead of going to a particular person, is going to his car driver, or it is going to his cook's number. So there is also, the public are also responsible. Today, it has to work on a public-private understanding. It has to be a public-private. And coming back to the hospital sector, see, whenever, because it's impossible for any country to build such a huge medical infrastructure and keep it vacant in anticipation of a pandemic. But one, particularly our semi-urban and rural health structure has been exposed now in this particular thing. Particularly, you look at the fatality rate. In Bangalore, it is coming down, but the fatality rate in the district is going up, exposing the health structure in the semi-urban and rural area. And the treatment, see, as more and more time has gone by, we have understood the virus better, we have understood the disease better. The strategy of treatment also has significantly changed from March to August. See, today, if somebody is having moderate symptoms, there are excellent broad spectrum antiviral drug like remdesivir, and government of Karnataka has procured nearly 15 to 20,000 remdesivir today. So I think we are understanding the disease far better. Of course, convalescent plasma therapy is another one. So definitely, we are knowing this disease a lot better over a period of this thing. Our treatment strategy also has improved. I fully agree. We need to expand our bed capacity. We need to, and here comes cooperation of the private sector, because we have to work in tandem. Government and private sector has to work in tandem, and we need to incentivize. We need to really incentivize these frontline warriors, Paura Karmikas, or ASHA workers. I fully agree with that. And even the doctors need to be incentivized. And this is how we need to really build up confidence among the healthcare workers. Another important thing, there has to be a dedicated hospital for the healthcare or the frontline warriors in case they get infected. Otherwise, they will get demoralized that in case they get infected, where they should go. I think these are some of the things, but definitely it has given a lot of food for thought. So we have to move on with this.
There's another question from an anonymous attendee. He or she asks, why is treatment so expensive?
No, treatment, government has come out with a package actually. If government send, because 50% of the beds need to be given to the government in the private sector, whether it is a private hospital or a private medical college. So they have two categories. One category, if it is a BPL or coming under the Karnataka or Ayushman Bharat scheme, or the Karnataka Ayushman or Bharat scheme, so they have one package and it is totally covered by the government, it is free. Suppose if it is for an insurance category, if there is an insurance category, the government also has fixed the rate. If it is only ward, it is around 12,000. If it is a single room, it's about 15,000. And with isolation, with oxygen, it is 20,000. With ventilator, it's 25,000 per day. So government has fixed. Again, problem is there are some patients going walk-in. So if they are a walk-in patient to a private hospital, their own policy, the billing policy, I mean, always is applicable. But at least there has to be, of course, it is left to the wisdom of those hospitals. It's left to the broad-mindedness of this hospital, because we can't really regulate all those things by iron hand. So there has to be a kindness. Kindness makes the person most beautiful. So however one may look like. So I think here probably this is how one can, because there is a structure, there is a system in place. So this is time, and there is also a scare. See, people are telling, okay, we can employ youth, and also youth are also afraid. See, government is calling into to appoint staff nurses, the technicians, even volunteers, giving 30,000 salary. They are not coming. Their parents are not allowing them to appear for interview. So the logistics are totally different. This is where it is a warlike situation. It's more beyond a warlike situation. So are not that easy as to talk, but definitely the virus also is, I mean, regarding youngsters, people are telling a lot of 30 to 40% of deaths are below 40 years. So same viral load, different patient behaves differently. So there is an issue whether there's any genetic predisposition for this viral multiplication. I have seen a report coming as high viral load, absolutely asymptomatic, not even little bit of headache, that's all. And another case, a low viral load, but patient is having lung involvement, is in shock. So these so 1 + 1 is not equal to 2 in medicine.
Right, sir. I hope our viewers understand that. Dr. Gururaj Kulkarni asks a question to you, Dr. Rao. COVID-19 research related to herbal drugs. What is the present scenario, Dr. Rao? You unmute, sir?
Yeah, I have. Sorry. So Suraksha, sorry, can you just repeat the question?
Yes. He asks, COVID-19 research related to herbal drugs. What is the present scenario? He's addressed.
So now I'll give you a very interesting background to this. So we were on, Emory University, Atlanta, their vaccine center spearheaded by Dr. Rafi Ahmad has actually been helping us through and through with a lot of guidance on neutralizing antibody titers for plasma and several other things in the vaccine thing. So one of the things that we had with their dean as well as the directors of Emory, one of the video calls, we actually had pondered upon this thing that today there is no way to find a new drug because we don't have the time to find a new drug. The only way to work this out is through repurposing old drugs. And there are at least 1 million molecules that are there. So we thought, why not look at the possibility of collectively repurposing any of these potential drugs? So the questions we had in hand was, can we repurpose some of these particular molecules? So in this particular context, there was Dr. Shashank's group, which was actually working. He's an intensivist from UK, who's got his expertise in both secondary metabolites as well as in bioinformatics. And we took help from Elseviers, again, to use their pathways to look at the key targets for transmembrane proteins, spike proteins, and nuclear proteins, along with ACE2 receptors. We found among the 40,000 searches that we did in the docking, we found at least about 37 of these particular components, these herbs, were effective. Now, these particular herbs were again published by the Lancet, proved that they are against SARS-CoV-2, they are very effective. And that's why we thought, why not look at docking these and seeing whether they will be successful in containing them. So when we did that, and so this is not pure Ayurveda, this is actually pure starting with allopathy. We looked at bioinformatics, we looked at repurposing, we looked at docking. and we looked at computational biology in this. We were able to find at least 37 of these components which were very active, and among them 18 of them were freely available under the Ayush Ministry approved as medications. So we said, now let's not reinvent the wheel. If we are able to see that there are, and in docking, this actually gave us almost about 100% hit. So we said, if we are able to understand this, this could be our only simple way forward to make an attempt. So here we are not talking about just Ayurveda, but what we are talking about is collaboration beyond this, because the virus doesn't understand Ayurveda, allopathy, homeopathy, and Unani medicine. What it understands is it's a part of nature. So we've actually been trying to foster collaborations across unusual common ground. No, Ayurveda doesn't want to talk to allopathy because we don't get along with each other. Our ethics committees are saying, no, we are not experts in this, we will only do that. But can we look at a collective solution? So we've actually tried to bring in synergies beyond individual differences to solve a larger community problem. And the intention and the effort is sincere to see, can we, the World War C, I call this the World War C. So the World War C has only two answers, collaboration and not competition. So I believe all the C's are right here, So we have to look at collaboration at this juncture to win this war. Otherwise, we are going to somewhere miss the boat in this. So that's what we are currently working on, allopathy, immunology, and collaborating with Ayurveda, with all due respect to all these fraternities, to come together and solve something in a collective.
Yeah, whether it is allopathy, naturopathy, homeopathy, you should have sympathy for the patients.
That's a nice way to put it, sir. So V.S. Seshagiri Rao has a question. Are there any chances normal flu symptoms and breathing trouble for other reasons be identified wrongly as COVID by a COVID test? Dr. Manjunath, if you could answer this.
Actually, it is quite specific. SARS-CoV-2 test is specific, but most important thing, suppose a patient has a common cold or influenza-like illness and breathlessness. Suppose if COVID-19 test is negative, if there is a strong suspicion of COVID, you have to do this, CT of the lungs actually. And also there are some specific findings, COVID findings for the CT. I think a couple of days, one of our staff nurse had a breathing difficulty, tiredness, COVID-19 test came negative, and then we did a CT that was typical of a COVID. So I think sometimes there are more than one test to really confirm. Another under the umbrella, always under the pretext of COVID-19, now what is happening, they do the test and patient continues to have breathing difficulty. We should not mix other infections. N1 should not be missed. Dengue also should not be missed. It is happening. Even typhoid is being missed. So patients are, so other diagnosis, you should have a broader approach whenever a patient has got a breathing difficulty with a little bit of fever and all. It's not just COVID-19 alone. And yes, but the false positivity is not being talked of. And another question is about rapid antigen test. Somebody has asked about rapid antigen test. See, it is highly specific, but sensitivity is around 50 to 60%. If rapid antigen test is positive, yes, it is 100% positive. If rapid antigen test is negative, but patient is symptomatic, then we have to always follow it up with a RT-PCR test. If it is negative, but patient is asymptomatic, very low probability of COVID-19, then you can declare them as negative. So otherwise, yes, its sensitivity is around 50 to 60%. And another, even RT-PCR, if you do it very early in the course of the disease, maybe first 4 days of contact, it can be negative. So you have to keep your options open, and you have to repeat again at the end of 7th day or 8th day of contact if there is high index of suspicion.
Suraksha, another point, just another quick point on this. I've been reminding myself this, that the loss of sense smell is a pandemic. The loss of common sense is also getting to be a pandemic now. And I'm just telling this is also true for us healthcare workers, because every day wearing this PPE, I've been getting paranoid thinking I've got corona every day. And every day I get a small symptom, I start wondering that is this corona? Now this is happening across, because we as healthcare workers also, every single day we go through a small flu, we go through some headaches, we go through body aches, or we go through tiredness and fatigue. But today the condition is such that in every small thing we are sitting and thinking of corona alone. and we have forgotten non-communicable diseases, heart diseases. We had a patient sometime back who came to us with an uncontrolled diabetes and saying, I was worried about corona. I said, the main worry would be your diabetes or sugar, which is going to trouble you than your coronavirus. So I think somewhere there has to be reassurance among the people to not get panicky about one single thing and forget all the rest of the troubles of the world and assume that this is only the one that is existing today.
Right. Dr. Babu, if you could take this question from Dimple, she asks, we have heard of many young patients around the age of 27 and 30 succumbing to the virus. What might be the reason for the deaths at this age?
Yeah, so that's a very good question. So although we say that most of the deaths are above the age of 40 years, nearly 70% of the deaths are above the age of 40 years. We need to understand that even among the other young age groups in the adults, there is a wide undetected, sort of epidemic of hypertension and diabetes. Just to give you an example, 1 in 3 adults have hypertension. Only 50% of them are diagnosed, and even among them, 50% are on treatment. Now, we did a study all across the country, nine cities, and we covered even 11 states, but 9 major cities we covered. What we found was that it is led by our director, Professor GVS Murthy. What we found was 50% of the people were blind by the time they came to know that they have diabetes. So, as very well explained by Dr. Vishal earlier, I think there is a major undetected portion within the population of non-communicable diseases. In addition to that, there are also malnutrition. There is also a problem with the immune response in some people. So just because we don't know that the person has some comorbidity doesn't mean that they don't have it. So it's mostly undetected in most circumstances. Even otherwise, there is rare circumstances where people react differently. And that proportion is going to be a very minor proportion on how mortality is going to be explained. More on the clinical outcomes, probably Dr. Vishal Rao and Manjunath sir.
Yeah, I think we have done some auditing of this COVID-19 deaths. Nearly 22% below 50 years did not have any comorbidities. So they are pretty young, fit and fine. So I think we don't know the exact reason. So even virus can even bite the youngsters also. But we agree that the maximum deaths are after 50, those comorbidities. But even with young people without comorbidities, also they are not immune to the fatality.
I request any of you to take the next question. Vagesh TS asks, when in the opinion of experts can colleges reopen in Karnataka? If any of you want to answer this question.
What is the question? When can reopen?
Yeah, when can colleges reopen?
Raksha, you should give all the difficult questions to Giri. He answers them first and then we'll follow.
Okay, I'll take this. So, I mean, I wanted to answer for even the school-related issue earlier. For the simple reason that we don't know what proportion of children are malnourished and what kind of immune response they have. We don't know whether we are completely ready. And when you come to schools and colleges, I think we should not take uniform policy for the entire country. We should be looking at state-specific issues. Now, what's applicable for Mumbai is not relevant for Karnataka. Mumbai has gone through its the worst, presumably, but the cases are peaking in Karnataka state. Now, is this the time to open up schools and colleges? This is a question that we need to answer as the state. The answer for this question would have been different in the month of March and April, but not now. So they may not be affected, but there are elderly and others who are staying at home. So a considerate decision has to be taken based on the local evidence, especially at the state level in terms of reopening schools and colleges. I think we should wait for till the end of this month to know where we are heading before a decision can be made, at least in the state of Karnataka. That's all I can say.
Giri, to add to that point, I think what is also important for us at this juncture, and I think as policymakers, citizens, to reinvent the wheel and to look at how can we remain productive at this time without stopping the machinery. And I think that's the bigger thing that today policymakers will need to address. to understand what can we do to remain productive at this time. How can these children be productive? How can they look at it? What are the strategies we can adopt at this juncture? And there are interesting strategies that we will need to adopt maybe from other countries or re-innovate ourselves.
Actually, the Philippines and Singapore minister said, we will not send the children to school unless the vaccine is available.
You don't want to reopen educational institutions until a vaccine is available.
Yes, Dr. Giri said, probably now we are peaking, even the projection is, it is peaking is also going to last till October. So obviously, the reopening, probably that thing can be thought of only beginning of the next year.
Right, right. So there is another question from an anonymous attendee. He or she asks, why is there so much chaos in getting an ambulance, getting a bed in hospitals? Dr. Manjunath, if you could answer again.
I think I can understand, because there was more number of cases in Bangalore. Now they have created into 8 wards, and for the last 4 days, they have digitalized the admissions online. So online, there is beds or bed vacancy positions or admissions are made online. Probably this inconvenience will come down. I can't say it will come down to at zero level, this thing, but definitely these things are being answered. Just it has been digitalized, so real-time vacancy positions are available. So at this point of time, even 30% of the beds in both private as well as in the government sector is vacant, as per the data yesterday.
If I can just add, I think there are now ambulances available, the beds are also available. So at least even in terms of beds with oxygen, even that is available. So I don't think there is a need for panic now. There are 2 important issues here. One was a lack of primary health care in all the urban areas, including district headquarters, Bangalore, everywhere. So you simply do not have enough people to manage all these calls and then early isolation and all that. Once the system is put in place, mostly we're taking public-private partnerships and also other partners. I think it is working fine now. But these models should not be limited only to Bangalore. Even the district headquarters should be able to mount such responses as the surge in cases shifts from Bangalore to other places.
I just Giri, want to add 2 points to this. See, Suraksha, another thing that is happening is, why do we call an ambulance? There are 2 reasons. One is because it's COVID positive, so we want an ambulance. Because you can't be transported in a regular thing, that there is a panic. The second being sudden breathlessness. Now, breathlessness doesn't come in suddenly. It comes in through a phased manner. COVID is not like an acute MI where you get a sudden heart attack. What is happening is, I think, at the public level, there needs to be a lot of awareness that as you're developing the symptoms, don't keep waiting in your house, experimenting with medications. Yesterday, I had a patient who came to me saying for the last 2 weeks, he's been having fever, and saying that whether this is anything related to any other symptom. But I asked them, have you all gone into the fever clinic? They said no. I think there has to be a lot of diligence from the people side also to not neglect symptoms and wait until the last moment.
Right.
And also regarding this home isolation people, they have been given a pulse oximeter, of course, a thermometer also. I just wanted to emphasize that today in the market, there are a lot of fake pulse oximeter also. So one should be aware. Suppose if patient is positive and is on home isolation, and because the guideline says if saturation is less than 94 or 93, you have to report to the hospital. So I'm just trying to emphasize, before most important is you check 3-4 times. Your finger should be properly inside the pulse oximeter, and because there are some pulse oximeters I had seen, when your finger is inside, it reads as finger is out. And also then accidentally we want to just experiment, we put pencil, it is also giving some saturation. Pencil is a lifeless thing, it was giving some oxygen saturation. So I think this is where there has to be some calmness among the people, and they should talk to each other, and whenever there is doubt exists, they can call their colleagues, they can call their family members, or they can counter check with their own family members who are healthy or apparently healthy, so that for that comparison. Otherwise, we have seen patient rushing into the hospital. So my saturation was 90, so we have come here. Then we checked with the other pulse oximeter, it was 98, 99. So I think the pulse oximeter is also creating some scare. There are some good brands, one has to verify those things.
Suraksha, I think Dr. Shashikumar is waiting for a long time. You should ask him a question.
Yes, the next question from DH editorial is for Dr. Ganeshan. The government constantly points to deaths per million to say that the situation is not grave. But isn't this a false equivalency because a population is so large? Also, by the same logic, a large population is equivalent to a relatively low death rate per million. Shouldn't we have more testing per million?
If you want to answer this question without any diplomatic way, yes, obviously we need more testing, right? Even for me, one doesn't matter whether the casualty of maybe one number or 100 number, we have to treat each and every life equally, right? So yeah, of course it's less, but it's we cannot take it lightly. So we have to definitely increase the testing. And for example, when we are saying that, okay, we are seeing only like 50 or 60,000 new cases per day in the last 5-10 days, but that's not exactly reflecting the reality, right? So for example, when we have 10 lakh active cases, right, probably they will be infecting 1 lakh per day. Now we are in the situation like 20 lakh active cases, so they will be infecting 20 lakhs. So have we increased the number of testings? If we don't increase the number of testings, we may not be able to see the number of new positive cases as well. So to answer it correctly, yes, definitely we need to increase the number of tests. And when we increase the number of tests, obviously we'll be able to identify positive cases, and we will be able to quarantine them, and obviously we'll be able to contain the spread. So
I can just quantify Dr. Ganeshan's thing for a difference. An epidemiologist quantifying mathematician's answer. So, see, currently we are doing 15,000 tests per million. If you look at Qatar, they have similar hospital and doctor-patient ratio, but they do 150,000 tests per million population. So if you ask me, we should at least increase the testing rates by 10 times.
Right, we do. So can we take the poll? Can we take the second poll results now? Yeah. So 85% of our respondents say that we will resume life with restrictions in a post-restricted world. Claps from Dr. Babu for the response. 12% say that resume life as and when required. And 3% say resume life as if everything's back to normal. So most of our viewers are responsible. They will resume life with restrictions.
Yeah, so I just want to add one point here. So we should not take it, whatever the behavioral change, as a restriction. So if we started to look it as a restriction, then it will become a burden, right? It should become a habit. And it is nothing new for the Indian culture, right? Even this, for example, say, we have been telling, right? Avoid handshake, right? Say namaste and namaskara. All these things, right? So when you go out, come in, you wash your hands and legs, all these things, hygienic things. It's in the culture. We are reinventing them. And only request is we should not take it as a restriction. We should bring it as we should take it as a habit.
So Suraksha, you all should have had option number 4, which said that get back to new normal.
In hindsight, yes, we should have had that option. So, sir, we are at the end of the webinar. We couldn't take more questions. I'm sorry to all the viewers whose questions couldn't be answered. So, can we have final comments from all of you on how the pandemic will see its end? So, Dr. Babu, if you could go first.
Yeah, so like everything, this shall too pass. And whether we learn to live with the virus or not, the virus will learn how to live with us. It is not going to result in everybody's death. So it has to ensure that we are alive so that it can also remain live, and it also needs to replicate. But while it is learning how to live with us, we need to avoid 3 C's, which is crowds, close spaces, and close contacts. And we should follow 3 W's: wear mask, watch your distance, and wash hands. This is my concluding remark. Thank you for having me on this panel with the esteemed panelists.
Dr. Manjunath.
Yeah. So actually, virus is going to stay longer, and we have to balance life and livelihood. That's very, very important. And virus doesn't move. It's only the people are moving the virus. And have some sympathy, kindness for people who are affected. Don't try to stigmatize. And another important thing, a dead person never spreads the virus. So there is a fear among the people objecting the cremations or burials. It's totally unscientific and inhuman, and because a dead man cannot talk, cannot sneeze, cannot breathe, so watching the dead person from a distance, or those who are in the neighborhood, if it's buried there, it's I think this is where we have to really sympathetic towards these things. You should be scientific, and if you want to avoid ICUs, wear mask properly, and if you want to avoid ventilators, maintain a good physical distance of at least 6 feet, not 3 feet now, and avoid gathering. And also the duration of contact, keep it short. If it is less than, even if you're talking to an infected person from about 6 feet, from less than 5 minutes, your chances of getting infection is very less. So respect all those things, and wearing masks should become a part of our culture, Japanese culture. So even before this endemic or pandemic, Japanese, right from the school days, they get into this culture of washing their hands, washing their face, and cleaning their shoes and all those things. Become a part of our culture from here onwards.
Right. Dr. Ganeshan, your closing remarks.
Yeah, so I think it has been said. I mean, it's all right. So wearing masks, maintain social distancing, all these norms one has to very strictly follow in order to contain the spread. In addition to that, right? So when we are talking about the education, also a lot of questions also arise, right? So in this situation, we should also bring probably we are going back to the Gurukula Kalvi, right? So probably with internet. So that's the only difference. So we should also learn how to learn from the internet on self-learning. All these things one should develop, right? So that that's the only way to avoid any drastic effect or the effects of this pandemic, right, in the education system. Yeah, people should, students especially, should learn how to do studies by reading on their own, probably less watching other contents on the internet, more watching on the educational content.
Yes. Dr. Rao?
No, I think Giri stole my slide of the concluding remarks. On a lighter note, but I think today we saw socialism, we saw capitalism, we saw communalism, and possibly some aspect of corruptionism. I think we need to hope and pray that humanism finally emerges and we become victorious. I think that should be the closing point from my side. Thank you very much.
I thank all of you for joining us today at Tech and Health. I request all our viewers to register for the webinar so that your questions are taken on priority. Thank you so much for joining us, everybody. Gentlemen, thank you so much for joining us.
Thank you. Thank you very much.
Thank you.
It was nice interaction. I also thank all my friends, colleagues. At least this is an occasion to talk to all of you. Otherwise, we are getting isolated for this pandemic. We are ourselves getting isolation. Loneliness is also becoming a common problem. Loneliness is a mental disorder. 1 in 8 in India today is having loneliness, and pandemic is adding to the loneliness.
Thank you, sir.
Thank you, sir. Thanks, everyone.
Thank you. Thank you. Thank you, Vishal.